Well, hey everyone. Welcome to TLB Snack Chats. Today we have our first special guest of our Snack Chats, which it's going to be a really great conversation. But this is Dr. Berens. Did I say your last name right?
Yeah.
Berens?
hmm
Amazing. Um, and so we are going to dive into today and talk about how we work together in eating disorder care and what medical providers or just any provider, what we need to know. So that's what we're going to be chatting about. But Dr. Berens, can you tell us a little bit about who you are? Where are you? What do you do? All the good stuff there.
Yeah. So I'm a family physician and I own Vida Family Medicine, which is a primary care practice in Sugar Land, which is a suburb of Houston. I see patients of all ages, but predominantly the majority of the patients that I see are people who either have or have in the past struggled with disordered eating, whether or not it qualified for a full eating disorder diagnosis or not, but just people who've really struggled with their relationship with food and body. And, I work with them on addressing their health issues, general primary care stuff like their cancer screenings and their vaccines and, the routine lab work and things like that. But then if they have medical conditions, also addressing those issues and approaching that from a weight neutral perspective to keep in mind their history and not wanting to, making sure that we're not falling into a relapse of those disordered behaviors.
Can we like copy and paste you and put someone like you in Austin and literally everywhere else that a human lives? Like, yes, yes. I'm so happy to have you as a resource, even for TLB as a virtual resource. I mean, we have a dietitian in Houston, so yeah, plug in that. But such an amazing resource. I love that you do primary care, but also really hold this specialty and or just awareness. We'll talk about resources in the end of like how to get in touch with you. And I know you have a few other resources to provide, but we are going to dive in. And so can you talk to our listeners a little bit more about whether you call yourself an eating disorder doctor or a specialist or just someone with awareness, when you're working with an individual where you're suspecting potentially disordered eating disorder, some fiddling with food or possible malnutrition, what are you assessing?
Yeah. So, I always like to come at this like every patient deserves to have a full assessment of their whole lifestyle, behaviors, all of that, because that's most of what we can control around our health is our lifestyle and behaviors, and even
Right.
some of that we can't control,
Yeah.
right? We're not always in control of our environment and all the other things that affect our lifestyle, but I think for the things that we can control, I think it's really important to have a thorough discussion about it. And so this is something I do for every patient, regardless of whether they are referred to me because someone thinks they have an eating disorder or they've experienced struggle, they're in treatment, whatever. I'm doing this for every patient.
Yeah.
And so, what that looks like is just doing a full assessment of health, past medical history, family history, current living circumstances, employment circumstances, all of the life and genetic things and history things that affect your health. We got to have that framework to know where we're coming from. And then we want to look at your basic lifestyle and behaviors now, like what's going on now, not just with food and exercise, which is what I think a lot of people tend to focus on when
Right.
it comes with lifestyle and health, but what is your sleep like? How are you managing stress? What stressors are there in your life? What like environmental and socioeconomic factors are actually impacting you right now, and what can we do about them to help you manage them better?
Yes.
Um, and then, looking at any substances that you might be using, whether that's caffeine or alcohol or cigarettes or other drugs, looking into the big picture of all that. So I always tell it's like my five S's. We have sleep, salt, which is what I is my standard for nutrition. Sedentary, are you sedentary or not? Stress, and then substances. So that's my like five
I
S's
love this
for
little
everything.
trick. Okay,
Yeah.
five S's,
Yeah.
noting,
Yep.
noting.
And so everyone should have that assessed because generally
Sure.
speaking, one of those is not going well, at least for most people.
Mhm.
And there's always things that we can do to intervene. And I think, like I said, so many people focus on the diet and exercise piece. to the point of like significant restriction or over exercise, or like they're really like hammering in at the diet and exercise. But if one of those other things is on fire, that stuff is not that important.
Right.
We got to address those other things too. So it's a big picture that we're looking at, and especially when it comes to stress. You know, what we're talking about there is, you know, those socioeconomic factors that you may or may not have control over, connecting you to resources to manage them, and then your mental health.
Hmm.
I think that's such a neglected part of physical health is actually mental health. And we can't expect that you're going to feel better physically if we're not also addressing what's going on for you mentally. So that's sort of like my general approach to anyone, eating disorder concern or not. And then from there, we'll do a thorough medical assessment and intervene where we need to intervene. But
Right.
it has to start with that sort of baseline evaluation of knowing where we're starting from, not making any assumptions about what's going on based on any medical conditions you have or what you look like or your weight or whatever, where we start with asking the questions, hearing from you what's going on, what your goals are, and then we go from there.
I love this because, to be perfectly honest, you haven't even mentioned anything medical, right? Like, and so it's like, how relieving to be like, if every person got this kind of care, which ultimately is time and curiosity, if everyone got that kind of care, then I feel like the health system as a whole would be so much better. Like, you're bringing in social determinants of health, you're bringing in mental health, and really enhancing on how those areas affect our physical health. And so, yeah, it is. I love this. Y'all, we're talking to a doctor here, and you haven't mentioned anything medical. It's amazing, right? We're talking about how to assess health, and you're just giving people time and opportunity to share more about themselves. So, yeah, I mean, this is kind of a systemic issue where doctors need ultimately time. And so that's where it is kind of a bigger systemic issue for finances and insurance, and who knows who has time to actually do these assessments. But if time is available, then how cool to just really get to learn about your patients a little bit more. Um, I love that. Can I come to you? Uh, yeah. So if we were to, okay, you have this like baseline, you've gotten to know them, you kind of have a path. What would be some of the medical markers that you would be wanting to assess to actually determine, ooh, maybe there is something a little bit more medical going on? We don't want to keep it broad spectrum because I know, like, okay, how many hours do we have? But more so specific to disordered eating, eating disorders.
Yeah. So, I think the first part to start with after like sort of assessing our baseline is like, what is the patient's goal? Because that tells you a lot about what is the most bothersome to them. Like
Mm,
I always ask people, tell me what are your top 3 goals related to your health, because that tells me what's bothering you the most. And that like whatever's bothering you the most is probably the most severe thing going on.
mhm.
Not always. Sometimes things are going on that people don't recognize, but it just gives me a sense of like, okay, you're really feeling like this needs to change. So this is somewhere we need to dig in. But so I like to always start with having what the patient's goals are because it gives me sort of a direction of where my concerns might need to be. But for every patient, we're doing a full set of vitals. And for patients, particularly with nutrition concerns, I'm usually doing orthostatic vitals. So we're going to be doing, heart rate and blood pressure, both lying down and then standing. Um, and um, and then we're going to be doing height and weight. I do check height and weight on all of my patients.
Yep.
But this is just baseline measurement to know kind of where we're starting from. And then we're going to do head to toe physical exam. And particularly in patients with, there's a concern for disordered eating or malnutrition, I'm going to be looking for any signs of malnutrition.
Mhm.
And so that can look like, decreased circulation, particularly in the fingers and toes, where they're feeling cold or they're not, rebounding. If you kind of press gently on the end of your finger, it kind of turns white and it should rebound pink pretty quickly. Um,
Mhm.
and if that's not happening, that's an indication that your circulation's off. We're going to be listening to heart and lungs, make sure we're not hearing any abnormal heart sounds that can sometimes be heard in particularly more severe malnutrition. We're going to be assessing the abdomen, make sure the liver is not enlarged, see if we're feeling like a lot of trapped stool, doing that sort of assessment. Then we're going to be looking for swelling in the legs or feet that we can sometimes see with malnutrition or with other metabolic health conditions. So it's really a head to toe exam. A
Yep.
big one that I always do is looking in the mouth and looking at the throat to assess the airway, because
Oh,
a lot of people who struggle with metabolic health problems, which are people who are commonly going to fall into disordered eating patterns, have sleep apnea. And sleep apnea is super underdiagnosed. It's very highly correlated with PCOS,
uh-huh.
which, I'm sure as a dietitian you run into this with patients. PCOS is a risk factor for developing disordered eating just because of some of the metabolic outcomes that has for their body, and then
Right.
also their general approach is lose weight. So of course, if you tell someone to lose weight, they're going to fall into some diet patterns that may or may not be beneficial. And so assessing for sleep apnea, and I do find it quite often. And of course, me looking in your mouth doesn't tell me if you have sleep apnea.
Sure. Yeah.
But I can kind of look and see like, oh, that airway looks a little small.
Mm,
And then it kind of prompts me to ask some more questions. Of course, I'm asking about sleep anyway at the beginning, but sometimes people will say everything's fine. And then when I look
right.
at the airway and I'm like, are you sure? Then some more
Right.
stuff will come out. So that's a big one that I'm always assessing for too. And then, of course, we're going to be doing lab work. And for someone with disordered eating, we may not see any lab abnormalities, but in very severe cases of malnutrition, we may see things like electrolyte abnormalities, um, organ damage concerns like elevated kidney markers and liver test markers. We may also see evidence of protein in the urine.
Mm,
And then, for a lot of my patients, we're looking at metabolic health issues related to, is there blood sugar problems? Are we having low blood sugars? Are we having high blood sugars? Is the blood sugar unstable and you're feeling a lot of symptoms because of the way it's fluctuating throughout the day? So we're going to be looking and assessing all of that with lab work. And, after that sort of full assessment, I will have them come back and we'll kind of talk about everything
mm,
to review those results and then make a determination from there. As I said, I do weigh everyone,
mhm.
but we don't talk about the weight number unless that's something that feels helpful to the patient. Most people, we just don't talk about the number. Some patients, it's not appropriate for us to talk about the number. So even if they want to, we don't.
Right.
And then for a lot of patients, they prefer to just not have to have that number enter into the conversation because it is such a source of stigma that they've experienced in the past. Um, they've maybe experienced some shaming about it in previous doctor's visits. They've maybe gone to the doctor for a completely unrelated issue and
Right.
had their weight brought up, and that becomes the focus of the visit, and they left without the actual problem they came in for fixed.
Right.
So we never focus on that number, but it is something that we, of course, do address.
Right. And I think that, we talk about this in a lot of our videos where it's like, it's okay to gather this information with consent or following the preferences that the client is sharing. Like, hey, I want a blind weight. Please do not hand me paperwork with it. I'm triggered by this, or I have medical trauma related to this. Okay, fine. But gathering it as a starting place and using it as a part of symptom-based treatment, okay, fine, right? Like, we don't want to completely neglect because it can help us learn more about ourselves, but it is not the main avenue and the direct and only avenue. Something that I love that you're sharing is that you call people back to have them come and discuss the results versus what I think a lot of times is happening is individuals are getting portal messages and kind of this copy paste generic recommendation, which isn't very individualized and can potentially cause harm. And we work with a lot of clients that have so much medical trauma and medical stigma that is a part of their story that it's almost like I have to avoid doctors as a result of this, right? Or I've shared with you my life story. I really am struggling, and you've just copied and pasted something that literally has nothing to do with anything that we've talked about. Or let's just use an example. We have a client struggling with anorexia and is significantly restricting, and their lipid panel came back elevated, which is a really normal sign of their body trying to protect themselves. And the copy paste message is cut down on your saturated fat. And the client's like, I don't eat any fat really. What are you talking about? Right. So like,
They're like, oh, I'm not doing enough. I need to restrict more.
let's just cut everything out.
Yeah.
Right. So there's so much individualized care here, which is what I love. And I love how you're sharing, okay, we're gathering this data and then we're kind of creating that story and treatment plan based on what feels accessible and feels very individualized. What I would say is a really common struggle as a dietitian who has a group practice. And so the client volume, there's lots of different experiences here, is that providers will come in and on the surface, the client is fine, right? So like we're sending over information that's saying this individual is struggling. They are potentially not going to be fully transparent because of their medical trauma. They and or are minimizing their struggle. They are coming to you for validation, and I am asking you to help us validate the actual struggle. And the client comes in and labs look great despite behavior shared and potential weight loss or weight gain and behaviors reported and us expressing our concern, and the doctor goes, you're great, keep it up, right? And it's like, oh, help us all. Or like they're approving exercise when it's medically inappropriate, or just validating weight changes when really the client is like barely eating nothing. So that's our frustration. And when we try to call doctors, again, this is a systemic issue. We're not here to point, but these providers, they don't have time to call us and we can't get in touch with anybody. And so the client's like, my doctor said I was fine because they're on this platform, so I'm fine. And
Yeah.
that's where we're at over here at this like kind of crossroads. And so do you have any advice?
Yeah. I mean, I feel like, this is such an issue. And I mean, this is truly why I am in private practice, because previous to being in private practice, I worked for a variety of safety net clinics, which I love. I love working with those patients and, providing them care that they otherwise would not have access to.
Right.
It is very high volume, very high complexity, and like you said, very little time.
Yeah.
So I would have 10 minutes for these patients.
Oh my
Okay.
gosh.
And you're talking patients who have 4, 5, 6 chronic illnesses, food insecurity, socioeconomic factors, impact. Like you cannot possibly do what I'm talking about in that setting. And
Yeah.
even if you have insurance and you're going to like a private clinic or a hospital-based clinic, if they're taking your insurance, they are having to see so many patients to keep the lights on because of what insurance reimburses, that it's just not going to happen. They have to like it's 10, 15 minutes
Right.
per patient. That's just what it is.
Right.
Um, and it's frustrating, but like as you says, it's systemic. I don't think it's an issue of these doctors not caring, not hearing. I think it's literally if
Right.
you're seeing 25, 30 patients a day and you get the labs back a few days later and they look normal, do you remember that whole conversation? Maybe, maybe not. You probably have like maybe 100, 150 labs to go through that day,
Oh my
and send
gosh.
back messages. So yeah, you're going to be using some pre-filled forms and you're going to be
Right.
sending it back. I think also a lot of doctors are really sensitive to trying to make things as easy as possible for the patient because they know how much the system sucks and they know how much patients have to pay out of pocket for that 10-minute visit, even though they have insurance. So like a lot of people have these high deductible plans now. These visits are not free. You're paying the full cost of the visit until you meet your deductible. So what will happen a lot of times is the patient will go in for their annual physical, which is free. They'll bring a list of problems, which is not part of an annual physical because an annual physical only includes screening tests. It does not include evaluation of any condition. So as soon as you start talking about complaints, that becomes a not annual physical visit and they have to bill you, not because the doctor wants to bill you, because the insurance says they have to bill you.
Oh my
That's how
goodness.
it is. So they'll come in with this list of things. The physician will do the best they can. They will order the labs. They will send the results to the patient. The patient is not going to want to come back and pay for another visit to talk about them. This, I mean, this
This
there
is
are maybe many
huge.
patients who do want to come back and talk about it, but the vast majority of doctors' experience is if they ask the patient to come back for a visit to discuss the results, they are angry. They're like, I'm not paying you again to talk about this, but how can you possibly have an in-depth, nuanced conversation about what's going on
No way.
without the time? Like the only way to have the
Totally.
time is to have the visit. And so it's very difficult. And so, I think what I would really advocate for is for people to go in and don't schedule an annual physical. I know it's free, but it does not include what you think it includes. And expect that you will be going back for a follow-up and
Right.
tell them you want to come back for a follow-up. I want to come back and talk about this with you, because they are going to try in their heart of hearts, they're thinking they're doing the best thing to like save
Right.
you money and time by sending you a portal message. But in reality, like if you want to have that kind of care, you have to have the visit scheduled. And that's why, like I said, I'm private because I am not bound by those sorts of restrictions. I don't have to bill a visit a certain way. Like we have a flat fee package, intake visit, which is really lengthy, and follow up. That's all
Yeah.
expected upfront. That's going to happen. And then we do follow ups as needed after that. And so that allows us to make sure that we're personalizing the discussion and the plan to you and what's going on with you. We don't have to like pack the schedule with 30 patients a day and then be
Right.
sending you these little, because I mean, I was in a position with one of my jobs in the past where I would log into my EMR in the morning and there would already be well over 100 things for me to address. Throughout the course of the day, more things are coming in, and these are lab results, these are refill requests, these are patient portal messages. I'm seeing 25, 30 patients that day in between doing all this stuff. And by the end of the day, the number has not changed. I'm doing it, but it's still there. And like, I think, it sucks for everyone. It sucks for the doctor. It certainly sucks for the patient. No one's happy with that dynamic. And so I think
Oh.
it just if you want to be able to have the conversations and advocate for yourself, you have to expect that it's going to take multiple visits. It's not going to be done in one visit. You're not going to get the answer you need after your annual physical. It's just not going to happen.
This is such a helpful perspective because it's like the doctor is miserable on the back end too.
Oh
Like
yeah.
what you're describing is the worst work-life balance I've ever heard of, right? And it is a really systemic issue. And so then we have, yeah, this is where the social determinants of health really come in. They want to, let's say an individual wants to focus on their health, but doesn't have the finances to be able to come back for that follow-up or pay into the deductible or doesn't have the session coverage because they have Medicaid or Medicare or whatever insurance nightmare it would be. And so it is like, okay, 15 minutes. Like I have to tell you my entire life story. Just send me a portal message. Bye. Right. Like
Yeah.
it's
It's not going to
terrifying.
happen.
Yeah. So that's so helpful for us. I know a lot of times we really rely on the nurse team, right? So like if we do get in touch with someone, they're like, just fax us a cover sheet and like in bold, really quick, what you want to address, or like client struggles with eating disorder, like
Mhm.
needs guidance, something like that. But most often, what I'm hearing is someone with potentially an eating disorder, disordered eating, really should be going to a specialist who potentially has more time versus a primary care or someone like yourself who isn't bound by these restrictions and has more of a membership type package where more time is available.
Yeah, because I mean, I think the part of it's the time, part of it, like you said, is the awareness. And like
Yeah.
I'm a family medicine doctor, so I did a family medicine residency. I did not do an adolescent medicine fellowship, which is where most people learn about eating disorders.
Mm,
I'm not a psychiatrist. Some psychiatrists have specific training in eating disorders, but PCPs in general, family physicians, internists, pediatricians, we maybe have a couple weeks. If we
wow.
rotated in an adolescent medicine inpatient unit, we maybe had a couple weeks of exposure to eating disorders. And those were obviously like the sickest of the sick, right? The inpatient patients. Very, very, very unlikely that we ever saw, to our knowledge, because we did, but to our
Right.
knowledge, a patient in an outpatient setting who had an eating disorder that we were aware of.
Wow.
The likelihood is just super low because it's not uncommon, but if you don't know what to look for, you can easily miss it, and the patient's
Right.
not necessarily coming in to tell you about it either.
No,
Um,
exactly.
part of their disorder is that they're minimizing their symptoms. They're maybe not being forthcoming, or they're ashamed and they don't want to, maybe they want help, but they're not sure how to say it, or they've tried in the past and been judged. They've had trauma. There's so many things that could limit the ability of them to share with you what you need to know. And then the physician may not have had any training in it to know what to look for. So it's really easy to be missed. And another thing that I think is really important for people to be aware of when it comes to PCPs is if you take insurance, insurances all have these quality metrics, and they're all moving to this like value-based care model, which means you get paid by the insurance company based on certain metrics for your patients. And those metrics are often things like blood pressure, A1C, which is the average blood sugar marker for prediabetes and diabetes, cholesterol panels, BMI. Okay. So if you are paid based on how your scores are on these numbers, those are the numbers you're going to be focusing on because
Wow.
otherwise your clinic can lose money. And that is, most physicians now are employed. Most physicians now are not, privately contracted with these insurance companies. But if you're employed, you are told by your employer, like, these are your numbers. What's wrong with your numbers? Why aren't your patients? So, like, yeah, if you see someone who comes in and their BMI is normal and their labs are normal, like, that's not a priority. I got all these other people that are very sick with severe metabolic health concerns that I'm getting graded on.
Right.
That's where a lot of the clinic resources are spent. And so these people get missed who are really struggling, and it's
Right.
not as if their condition is any less serious, but it's not flagging anyone. And the resources to address it are being utilized for other people who have more measurable, obvious conditions.
Right.
The other piece too is like if you are a private doctor taking insurance, you're probably not going to be open much longer because your rates that you're able to negotiate with the insurance company taking insurance are so much lower than what they would pay a hospital that you just can't keep up. You can't keep the lights on. And so a lot of private doctors are shifting to cash. And so it allows the more in-depth care, but it is a huge financial barrier for a lot of patients. And it's just a huge problem that, like you said, is systemic. And it's, we can't really point fingers at any one person except, I don't know, I feel like I want to point them at insurance company CEOs, but
Yeah.
a little bit. But it's complicated. And what we talked about earlier, the social determinants of health, like what the doctor is able to do in their visit is like this much.
Hmm.
It's so much everything else. It's so
Right.
much access to food, access to education, enough like safe, affordable housing that you can afford to keep the
Right.
utilities on. Like
Right.
all of that is so much more important than what's happening in the doctor's office. And that kind of stuff is really serious and an issue for a lot of patients. So that's where we're focusing the energy.
Right.
And so all of these patients who are really struggling just kind of fall under the radar.
It's really scary. I mean, it's kind of a bummer because it's like, okay, I hear what you're saying and it's all super helpful. I love the other side of it, like hearing that perspective. And then it's like, and there isn't really a solution in this, right? And so I guess just as providers really trying to connect with primary cares that are in facilities struggling and jammed back to back with clients, you know, I guess this is why, like, one of the benefits of working together as a team, where it pulls a little bit of that pressure off primary cares onto the other specialists, so that, okay, the doctor did a really basic assessment. Now we had a specialist. Now we had a dietitian. Now we had a therapist. Hopefully insurance can cover that, or, there's accessibility there. Again, much larger issue if we're talking about lack of accessibility, but this is one of the benefits of working as a team, which we love really doing, is like collaborating. So I guess that the biggest struggle is getting in touch with that provider. But we've been told facts information. Would you have a better suggestion? Or
Yeah, so that does get to the doctor,
yeah,
assuming the person assigning the faxes assigns it correctly,
right,
which,
yeah,
like these big clinics have like thousands of faxes coming in a day that
right.
someone's job is to click and assign to different people.
Yes, we see
So
the person that assigns faxes. Yes,
I know, so, it will get to the doctor and then it will go into that queue of 100+ things that they have to address that day.
uh,
And yeah, they're not going to call the patient when they get that. There's just not going to happen. I
yeah,
think if I were to have any recommendation for someone, if you cannot go to a private facility that is more specialized in this area, if that's not accessible to you and you're needing to see someone that you takes your insurance, you just got to have a regular standing visit
yeah,
every month at least while this is going on, because
yeah,
that gives them the time to review what's happening and to build up some understanding over time of what's going on.
right,
And like I said, they're probably not going to suggest it because there's a lot of pushback every time we tell someone to make an appointment. Um, if you're in that environment, usually people are trying not to come in because they don't want to pay.
right,
Um, but if you're able to go in, especially if you have an insurance that's copay only for
right,
that PCP, the cost, it's a cost, but it's not as inaccessible maybe as going completely private. And
right,
it just is going to require frequency and follow up for them to be able to have the time and space to like receive that information that you've sent them, internalize what's happening and understand the situation better. And then over time, build that rapport with the patient to better understand what's going on. Because if you have 10 minutes, I mean, you're skimming the surface, you're looking for the biggest red flags. And
right.
as like the medical things that come up for these patients usually are subtle, especially at first. By the
Sure.
time they're obvious, we're in a much different, we're not outpatient, right?
Right. Or their
Um,
body is so adapted to everything that they
yeah,
really do look
yeah,
great on paper,
yeah,
right? But with time, then we're learning, oh gosh, this person is really struggling.
yeah.
So what I'm hearing is, which I think is a great suggestion, in outpatient care, really we're bringing to the surface more consistent appointments as the client can. We've also thought about like clients bringing in like a medical resume to the
Mm-hmm.
doctor, like, here's my issues. We may not have time to go over it today, but this is something that I think is important, right? So it's putting accountability onto the client of like, here are my actual struggles, because again, there just is no time. And you put it into my head, okay, we may fax something that goes into the queue of 100 things. I'm like, I didn't even think about that. It's not like they're like, la, 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 la. Look,
Oh no.
an email or fax from
Oh
TLB,
no.
waiting all day. Thank you. Right.
No.
So
Yeah.
putting a lot of that onto the client, but
Yeah. I mean, if they can bring it with them in
yeah,
person, like a letter from you
yeah.
that's just
A
like, this is
letter
from
from
my
us.
dietitian. Please read it. Don't read it to me. Don't tell me anything that's in it. Just read it and then we'll go from there. Because I think there are patients who come in sometimes with this high stack of medical records. And when you have 10 minutes, you're like, oh my God.
I can't look at any of
Like
that.
you
Yeah.
just you did immediate like I'll just for the doctor's reaction, you're like, that's a lot of stuff I'm not going to be able to read today. Like, what is in there that I'm missing? Like the doctor side, the fear is like something really important's in there and I'm not going to find it. So
And
if you,
reading medical records, like, ugh, it's like
most of it is trash. Most of it is like
trash. I'm like,
random
yes, I've
EMR
seen
spit out.
this.
Yes.
Okay. You don't
Yeah.
need to list the grandmother's
Yeah.
history.
Yeah. Every page it's in there, right? So if you can be like quick summary,
Quick
bullet points,
summary.
Client hands it to the doctor reads it, go from there. Or even for the patient, like, these are the things I want to touch on today. And if it's more than three things, it's not going to happen. It's just not going to happen. Like, there isn't time.
Yeah,
To try to make it like your top three biggest things. Because one of the things that I think a lot of doctors try to do and struggle with, or get a lot of pushback in, is like agenda setting. Like,
right,
we have this much time. I don't want to rush you, but I want to make sure we handle the things that need to get handled today. What are the things? Because what the worst thing that happens is you spend like all 10 minutes talking about something, and then you're about to leave and you're like, oh yeah, by the way, I've also had this crushing chest pain every time I walk up the stairs for the last week. That's important. I can't ignore
yes,
that. But now I don't have time to talk about it, right? So like, write down your list of things,
yeah,
like, as you go between appointments, write down the whole list, and then before the appointment, prepare yourself. Like, okay, what are the top three things that I need to make sure I talk about with my doctor today?
right.
Um, and and don't make it the like rash on your toe if there's crushing chest pain, right? Like,
Yes, let's
prioritize,
prioritize.
prioritize, because then you won't make such more efficient use of the time that you have. And like,
Right,
again, it's gonna take, if there's a lot going on, like I always tell patients, particularly like disordered eating patients, right? As long as it took you to get here is as long it's gonna take for you to be in middle school with disordered eating, and you are 30. When you are 31, you will not be cured. Like,
right.
this is a many year process
Yes,
of unlearning and relearning and recovering. Like, it is not going to happen overnight. It's going
right,
to take time, and it's going to be incremental improvement over that time, but we have to expect that it's going to take time, and we can't rush the process, because that's just frustrating for you to think that it's going to be better when it's just going to not be better yet.
right,
So if you could go in, plan on recurrent visits to gradually address things that are coming up. And it just helps, the doctor over time better understand what's going on, because they just don't have, like, I spend an hour and a half with my new patients. And we still don't get to everything.
it's luxury, yeah,
Yeah,
but
we
and
still don't
that
get to everything.
of
Like,
course
you have
not,
10
yeah.
minutes.
You
So
said
you're not going to get to everything. Um,
Oh my
and like,
gosh.
I've heard of some doctors literally going in and setting a timer. That feels a little stressful to me, but like, sometimes that's what you have to do to survive that environment. And that is honestly, like, you got to be realistic. It's
I
going
mean,
to be 10
that's
minutes.
it gives me anxiety. Like
Yeah.
we have sometimes 25-minute appointments, and these are for our more advanced patients, just check-ins, whatever. That feels like too little of time,
Mm,
right? And we're just, how's it going? How have the goals been? Like it's really just maintenance.
yeah.
And that feels rushed at 25 minutes. Now we're talking about really specialized care in 10 minutes. So I love how like the viewers maybe don't know this, but I'm going to put the transparency. We have this whole list of points and notes that we're supposed to be addressing, but really, this is the beauty of the conversation, that it gets guided. Like, I had an idea, like, okay, we're going to talk about these things. And now here we are, where I'm like, oh, wow, you've opened my eyes to this perspective of these providers are really struggling on the back end. And it really isn't that people are just like, wanting to be neglectful. And I never thought that, but really it is a systemic issue and a system issue. And so the key points that I'm taking away, and maybe you can add or whatever, but is that consistent appointments really are going to be the best, because time is just not on the patient's side or the doctor's side. In that consistency, bringing in 3 points to address kind of level of urgency priority here. A medical resume is always welcomed, or a letter from the dietitian or provider or whatever that goes directly to the doctor in that time. Anything else that you would recommend? Because the majority of our patients, like, of course, we're going to recommend sending to doctors like yourself with the membership, but a lot of them, the Medicaid, the Medicare, the really financially strained individuals are going to stick with these providers that have 10 minutes. So anything else you would want to add to that?
Yeah. I mean, I think the only other thing I would add is just like expectation management.
Mhm.
So, like the medical resume, like you said, like if you can get a letter that's like from the dietitian. These are the things I'm worried about. If the patient can also on their resume have like a quick summary of the workup they've already had. Because a lot of these patients too have
Mhm.
had a lot of symptoms for a lot of time, and they may have seen a variety of different doctors for them and
True.
had several more advanced tests done. So if you've already had a bunch of stuff done, if you can have a list kind of summarizing it all, and then have the hard copy records too, in case they want to see them, but just be like, you don't have to read all of this. I have it here if you need it, but this is like what everything I've already had done. It
Right.
just saves a lot of time. But I think the biggest thing is like, it's not going to be solved in one appointment.
Right.
And it's, I guess this is something I didn't say, which I think is important, is those consistent appointments with the same person.
Yes.
Um, and
Yes.
that unfortunately is increasingly difficult to do. And I
Right.
think that, I don't want to be all doom and gloom on this, but like recognizing that like a lot of this is not in your control, a lot of it is not in the doctor's control either. Um, and we are all doing the best we can. So recognizing it's going to take time and it's going to be slow.
Right.
Um, but there will be slow incremental progress if you can stick with the same person and go consistently,
Right.
because they will be able to understand what's going on. So I think there's that expectation of like, it's going to take time.
Right.
And then I think, especially when it comes to like advocacy regarding, you know, blind weights and not talking about diets and things like that. I think if the patient, particularly at that first visit, if they don't want to be weighed, they can always decline to be weighed. Um, there's often pushback from the office if you decline to be weighed, just
Especially
because,
if they're getting paid on these
oh,
markers.
yes.
You
So
opened
that's
my
one of the
eyes
reasons.
there. Yeah, the
That's
behind
one
the
of the
scenes.
reasons is like they want to make sure they have the data. Now they can put in patient declined and it doesn't ding them,
Right.
but the staff that's collecting the weights is trained. You must get this information, so they're going to push a little bit.
Right.
And so, I think if you're able to just be like, you know what, please don't tell me the number, but go ahead and get weighed. Um, you will not have to have so much of a push up front.
Right.
And then going to like as soon as the doctor walks in, just like, just let you know, I don't want to know my weight. I'm currently struggling with this and I want to focus our visit on this today without a
Right.
discussion of my weight. And to be very frank, like there are certainly doctors who may not be very accommodating about that. I don't want to claim that everyone's perfect and they're all going to do the
Right.
right thing all the time, but the vast majority of the time, like they just need to know. And if they print it on a paper or they offhandedly say something unintentional, it's not intentional.
Right.
It's part of the sort of like general procedure that happens there. And when you're high volume, like things just happen the same way every time. Just
Exactly.
do,
Yeah.
and it's not intentional, it's not personal. Um, but I definitely know how hard that is when you've already experienced medical trauma in the past and it's happening again. Like it is such a barrier. So the more you can say it up front and just like advocate for yourself, be like, I don't want to know. I don't want to know. If they hand you a paper, just throw it in the trash.
In the
Like
trash.
you
Yeah, we
don't
don't
have to
have
look
to
at
take
it.
it.
You
Yeah.
know, they're gonna give it to you. Just throw it in the trash. They have to like that's another metric. They have to give you the thing. It's a box. So it's a box they have to check. So like, please
Wow.
don't take it personally. They're not trying to harm you. They are just struggling with a system that incentivizes all the wrong things.
Right.
Uh, and
Yeah.
so, and if it's, I think the more that you go in empowered and ready to advocate for yourself, the better it will go. Um, and I think for a lot of patients, there's like this power dynamic that they feel like they can't say things or decline to do something that the doctor's asking them to do. I've heard this from patients before, and like you are ultimately 100% in charge of all of the decisions about your health. The doctor can make a recommendation, they can order a test, they can prescribe you a medication. They cannot force you to do anything. So anything they say to you is a recommendation. You are in charge, and if you do not want to do something, you are always allowed to say no. And I think there's just like some relearning that needs to happen for patients of like coming from a very paternalistic time in medicine. Like that culture is still there, but
Yeah,
you
that
are
white
you
coat
you have that
syndrome.
ability. Like please feel empowered to say no if it's something that you're not comfortable with.
Yes, we've created these really cute little cards, the Do
Mm,
Not Weigh Me cards, which has
I
a
love it.
fabulous YouTube video on the back. describing
That's
what you
wonderful.
can do and how you can advocate as clients. And, again, we tell our clients, if you want these, we'll mail you some, or they're on our website. You can print them out and give them and give them to your doctor. And this is just something you can add to the medical resume. You can put, I don't want to be weighed and I'm going to throw away the paper, right? So
Yeah.
this is helpful to know that they have to give you that paper. Thank you, fold it, right in
Yep.
the shredder, right?
Yep.
So all super helpful. We are actually going to create a really fun little handout of all the quick tips that you're giving us so that as providers, it is something where we're recognizing, hey, these are the points that we really need to hit. So this is absolutely fabulous. I feel like we could keep talking forever, and like we basically missed the last like 3/4 of the handout that we had created, but it doesn't matter because it's such helpful information of what we talked about. And this again is why I really believe why collaboration matters. We're here to learn and unlearn. And so this is where we're coming together and going, wow, what a very interesting perspective. That helps open my eyes to ways that we can really ebb and flow and adjust so that our patients who potentially don't have the financial access, how we can help them get more access with their 10 to 15-minute appointments. So this has been fabulous. Anything else that you feel like you want to add or anything you want to plug? Because I'm like, I know you offer some fabulous services and provider resources and all of that. I want to give you space to plug that.
Yeah, absolutely. I mean, I think, like you said, we could talk about this forever, and I'm more than
Ever.
happy to come back and talk about more stuff another time if you would like to do that. But
Yes.
yeah, so like I said, we do obviously see patients who are struggling with this, and so if you are wanting to do more of an in-depth evaluation and appointment without the 10-minute visit, we can do that for you. My practice is called Vida Family Medicine, and we're in Sugar Land, Texas, and it's www.vidafamilymed.com, and you can just click right there to go ahead and get booked with us. Um, but we do have some resources. A big passion of mine is providing education to both patients and other clinicians just to try to expand access in general to better care.
Mhm.
And so for patients, we do have a YouTube channel that is growing. It is very small right now. I'm trying to create some like short videos on frequently asked questions that I get from patients.
Oh, that's
Um,
fabulous.
so if you have symptom questions or general questions, like anything medical related, I'm happy to create a video on that. It may take me a minute, but I'm working on it.
Healing
Um,
is hard. Yes.
and then for clinicians, I do offer a monthly case consultation group where we talk about weight neutral care and how we can better collaborate with each other. So this is for therapists, dietitians, physicians, psychiatrists, anyone that is involved in treating patients who may struggle with disordered eating, which is everyone pretty much. That if you treat a patient, you have probably run into a patient with that experience, whether you know it or not. And just how we can better work together to support them. And so if you want to sign up for that, we frequently share the links on my social media, which is Rebecca Berens, MD, on Instagram and TikTok.
And I've been to that and it is fabulous. And I appreciate you providing that resource. I mean, anytime that a doctor is offering their brain, I'm like, yes, I will attend. And the YouTube, I love that. The frequently asked questions, what a fabulous idea. So again, this has been amazing. Thank you for taking your time and sharing with us the doctor perspective and for continuing to be a weight inclusive provider that we can use as a resource and that our patients can use. So
Thanks so much.
all right. Bye, everyone.